Welcome to an Good afternoon, everyone. Welcome to another session of Steps in program. So today's our topic is ECG. As you all know, ECG is one of the most basic investigations that we use in our ICU, as well as we have continuous ECG monitoring in our ICUs. So a basic knowledge of ECG is very essential for the nurses because they are the ones who are always at the bedside of the patient, and they are the ones who usually can interpret the ECG in the beginning before even the doctors arrive. So for this class, we have Dr. Devachandran. He is the head of department in critical care at Dr. Kamakshi Memorial Hospital, Chennai. He's a vastly experienced critical care specialist with over 20 years of experience, and I welcome him to take this important class on ECG basics for nurses. Over to you, sir.
Thank you for that very kind introduction. Good afternoon, everyone. Thanks to ISCCM for this opportunity. So this is the basics of ECG for nurses. So as Dr. Nilanjan mentioned, ECG is the most common monitor used in all the ICUs across the world. And nurses are the ones that not only monitor ECG, but also record the ECG in some situations on a daily basis. So it is important that you all know what it records, how to interpret urgent problems as and when it happens at the bedside for the patient that you are looking after. So I'm only going to touch on only three parts. One is the rhythm disturbance, two parts, rhythm disturbance, and a couple of slides on diagnosing a heart attack as and when it happens on the monitor, and then doing an ECG after that. So I'm not going to talk about changes in the ECG from electrolyte disturbances. Okay, so we will divide this into three parts. One is the clinical part of ECG. Second is the technical part of recording the ECG and things that you need to remember when you actually record an ECG. And then finally, we will have interpretation. And I have about 4 or 5 questions at the end, which you can answer. Okay. So, and this is what we were talking about. ECG is basically recording the electrical activity of the heart. So if you remember your anatomy, I'm sure you all read the anatomy in your nursing course. There are 2 types of cells in the heart. So the first group of cells are the muscle cells. The majority is the muscle cell, which are also called the pump cells. And the second type are the electrical cells. The electrical cells form the electrical circuit in the heart. Now, if you remember, when the electrical cells are also called the pacemaker cells. So when the pacemaker cells send the electrical signal to the muscle contracts, and that's how the heart beats. So just a quick look at the electrical pathways of the heart. I'm sure you all read this as well in your college. This is just a recap of the heart's electrical conduction system, as we call it. So the main pacemaker is the sinoatrial node, or the SA node. The secondary pacemakers are the AV node, or the atrioventricular node, bundle of His, and the bundle branches. So this is a picture. As you can see, the sinoatrial node is situated in the right atrium, the upper chamber of the heart on the right side. It's the pacemaker of the heart. It sends electrical signals to the AV node. From there, the electrical signal reaches the bundle of His. From the bundle of His, it goes to the ventricular muscles through the Purkinje fibers. Here, yellow is the conduction system of the heart. and the chambers are obviously depicted in red. So it's the pacemaker of the heart, the SA node. When you think about the situations where you do ECG in routine clinical practice, there are four main areas where you do. One is your continuous ECG monitoring. So what you do in your ICU with your monitor is the continuous ECG monitoring. The second one is when you record the ECGs. I mean, nurses who work in cardiac intensive care units, coronary care units will know that you will have to record ECGs on a regular basis in patients that get admitted with heart attack, rhythm disturbances, heart failure, or post procedures. So that is second. The third one, somebody gets admitted with giddiness, or they had what we call syncope, which is basically a brief loss of consciousness, or someone is admitted with a stroke. Then we put them on what is called the Holter ECG. I'm sure you all know the terminologies. And finally, majority of the hospitals have the exercise ECG or the treadmill ECG. These are the four situations where we encounter ECG recordings for interpretation. The basic continuous ECG is the common one in the ICU. It's less detailed, but it provides information, beat-to-beat information about the patient. 12-lead ECG is the gold standard. It's comprehensive, and when you record it, it provides all the information about the patient's heart's electrical activity. I mentioned when you do the Holter, exercise ECG is done to diagnose patients with diagnose myocardial ischemia, whether it is present or not. Continuous, why do we use continuous ECG in the ICUs? Because it helps with immediate recognition of a rhythm disorder. Critically ill patients can develop any rhythm disorder at any point in time. So having a continuous ECG monitor will help you recognize rhythm disorders straight away. You can also diagnose life-threatening arrhythmias, and using the information, you can manage the arrhythmias faster and better. So moving on to the nitty-gritty stuff, you all know what the ECG involves. There are waves, there are complexes and segments in an ECG. There is the first wave is the P wave, which is which represents the atrial contraction. The QRS complex happens shortly before the ventricular contraction. Remember, I mentioned the electrical activity happens first, and the muscular activity happens after the electrical activity. So the P wave represents the atrial electrical activity. It is followed by atrial systole, which is the atrial contraction. QRS represents the ventricular electrical activity. It is followed by ventricular systole, which is ventricular contraction. And T wave represents the ventricular diastole. So relaxation of the ventricle after the T wave happens. So you need to remember this. This is the damn basic of the ECG interpretation. So those are the waves. The complex is the P, Q, R, S, and T are the waves. Complex is the QRS complex. That's the complex in the middle. And there are segments. The two segments are PR segment and the ST segment. So we will not talk about the PR segment. We will only talk about the ST segment briefly. So ST segments from the S to the initiation of T. When it goes up or down, it indicates myocardial ischemia. It indicates some problem with blood perfusion to the heart. Okay, so that's the nitty-gritty stuff. Moving on to the technical aspect, things that we notice on a day-to-day basis, things that you all need to be aware of when you record ECGs. So lead positioning, if you have had formal training, you would do it accurately and appropriately. It is important to remember that, proper lead positioning will only get you a proper ECG. So there are limb leads, there are augmented leads, and there are chest leads. So the chest leads, let's remember the chest leads first, V1 to V6. V1 is placed on the right side of the sternum in the fourth intercostal space. V2 directly opposite on the left side in the fourth intercostal space. V4 in the mid-clavicular line. V5 in the fifth intercostal space, mid-clavicular line. Fifth intercostal space, anterior axillary line, and fifth intercostal space, mid-axillary line. So V3 is placed between V2 and V4. So V1, fourth on the right, V2, fourth on the left, 4, 5, 6, fifth, mid-clavicular, anterior axillary, mid-axillary, and V3 sits between V2 and V4. So the limb leads, when you place the augmented leads, then automatically the limb leads will come into place. You will quite often see the red clip, red for right. Red clip goes on the right side, right wrist. The yellow clip goes on the left side, the left wrist. The green clip goes on the left foot. That is the left leg lead. This is the left arm lead. Sorry. So the red is called AVR. The yellow is called AVL, and the green is called AVF. Quite often you will have a white lead, which is kind of a neutral lead, which goes on the right leg for recording. Okay. Looking at the normal ranges, the normal heart rate is between 60 and 100 beats per minute. Anything below 60 is called bradycardia. Anything above 100 is called tachycardia. I will not go into PR interval or QT interval, but we will only talk about the QRS complex. The QRS complex, comprising of three waves, Q, R, and S, is generally less than 120 milliseconds wide. So we'll look at it using that graph paper in a minute. Okay. So this is the normal ECG, which you all know, which you all record on a day-to-day basis. There are two things apart from the lead positioning, V1 to V6, AVR, AVL, AVF, and the white lead to the right. You need to remember two other things. You must enter the patient's name on the machine itself. Nowadays, all the machines have the capability to enter the patient's name digitally. Nowadays, writing the patient's name with a pen on the ECG is not accepted. It must be entered on the machine. Number one, the time of recording, the date of recording must also be checked and confirmed. That's number two. Number three, there are two things, two arrows here. You need to make sure that the standardization, which is this rectangular kind of a waveform that is given by the machine, seen on the right end of this ECG, is 10 millimeter per millivolt. And the speed of the paper should be checked to make sure that it is 25 millimeter per second. So these two things you need to remember. The standardization should be 10 millimeter tall, and the speed should be 25 millimeter fast. So two things you need to remember. I'll show you why it is important. So as I mentioned, paper speed should be 25 millimeter per second, and the gain should be 10 millimeters tall. So these are examples of a change in the speed. So the bottom one, ECG was taken at 25 millimeter per second, the normal speed. The top one taken at 50 millimeter per second. So if you look at the difference between the two ECGs, here the interval between the two R waves is very wide. So you see 1, 2, 3, 4, 5, 6, 7, 8 big boxes between the two R waves. Here you only see 1, 2, 3, 4 big squares between the two R waves. So when it comes to calculating the heart rate, which we will talk about, what we normally do is when the ECG is run at 25 millimeter per second, we divide 300 by the number of big boxes in the between the R waves. So here there are four big squares between the R waves, 1, 2, 3, 4. You divide 300 by 4, you calculate the heart rate as 75 per minute. If you do the same calculation here, 1, 2, there are 8 large squares. If you divide 300 by 8 by mistake, you will get a wrong heart rate and you will call this bradycardia. So that's why the speed is very important. This happens very often. Somebody fiddles with the ECG machine and they change the speed, and the wrong diagnosis of bradycardia is made across the world on a day-to-day basis. So it is important that you check the speed. The second is the standardization, which is how tall the QRS is going to be normally. So this is 10 millimeters tall. This is normal standardization. If by mistake it is 5 millimeters, then the QRS appears smaller. If by mistake it is 20 millimeters, which is really tall, then the QRS appears really tall. So if we fail to notice the standardization, then clearly your diagnosis might change. So when you record an ECG, you need to make sure that the patient name is entered, date and time are correctly entered, make sure that the speed is set at 25 millimeter per second, and the height of the complexes should be set at 10 millimeters. Okay, right. Those are the technicalities. So first we talked about the pacemaker cells, SA node, AB node, His bundle, and the Purkinje cells. Then we talked about the lead positioning, V1 to V6, and where you keep the AVR, AVL, and AVF. So generally, the way I remember, or across the world, it is taught is red for right, yellow for left, green for spleen. So that's how it is taught across the world. So you know, so that you can remember to place the leads correctly when you record ECGs. So moving on to rhythm interpretation, which is very important. There are several ways of interpreting the ECG rhythm, and this is just the simplest way I have here. You can use the 6-step approach to interpret any rhythm. The first question in the 6-step approach is there any electrical activity? Do you see any electrical activity on the monitor? Do you see any electrical activity on the ECG? Second is, what is the ventricular rate? We just talked about how to calculate the ventricular rate. It's basically 300 divided by the number of large squares between the two R waves. Third one is the QRS regular or irregular. Does the QRS complex appear at regular intervals, which means the large squares between the R waves, are they even equal between two R waves, or do they keep changing? So that is regularity or irregularity. And then the width of the QRS complex, how wide is the QRS complex, or how narrow is the QRS complex? Then, is there any atrial activity? Are there P waves? That is the question. Are there P waves? If there are P waves, how are the P waves linked to the QRS complex? That's all. 6 questions. Any electrical activity? What is the rate? Is the QRS rhythm regular or irregular? Is it narrow or broad? Are there P waves? If there are P waves, how are they linked to QRS? That's all. 6 steps we're going to go through. Right. And the most important question you should ask before the interpretation of the rhythm is, how is your patient? If your patient is well, not having any complaints, then you go and do your rhythm interpretation leisurely. If your patient is unwell, then there should be a sense of urgency. If your patient is unresponsive, then it doesn't matter what the rhythm is. You check for pulse. If they don't have pulse, you start ACLS straight away. BLS followed by ACLS, starts chest compressions. Okay, right. So let's go through the 6 questions one at a time. On the right side, you see 2 ECG strips. The bottom one has straight line. So whenever you see straight line on the monitor, you should think, first thing, you should check the patient. How is the patient? Because if there is no electrical activity, the patient is likely to have suffered an arrest or dead. Check the patient first, and then check the leads. Don't do it the other way around. If the patient is well, then check the leads. The patient is, unresponsive, then it is cardiac arrest, start CPR. So do you see electrical activity? The bottom one, there is no electrical activity. The top one, there is electrical activity. You see standardization to 10 millimeter. You see the P wave. You see the QRS complex. You see the T wave. And you see 3 complexes here. So there is electrical activity in the top one, no electrical activity in the bottom one. What is the ventricular rate? That is the second question. So it's basically, as I mentioned before, 300 divided by the number of large squares between the 2 R waves, also called the RR interval. In this example, there are 1, 2, 3, 4 large squares. So 300 divided by 4 large squares is 75 beats per minute. So large square is what the large square is, the square that comprises of 5 small squares. The little ones, if you add 5 of them, you see it's demarcated in thick line. That is the large square. The smaller square is the square inside the large square. So it's 300 divided by the number of large squares, that also called the RR interval squares. That gives you the rate. So there are 2 other things that you need to remember. I mentioned before, and many of you will also be doing this on a day-to-day basis as well. The ECG speed is 25 millimeter per second, which means, your small square is 1 millimeter, your large square is 5 millimeters. So per second, the ECG runs 5 large squares. So 1, 2, 3, 4, 1, 2, 3, 4, 5. Will be recorded in 1 second. So that's how ECG functions if you keep the speed at 25 millimeter per second. So the large square is equivalent to 0.2 seconds. Remember, if it's 5 boxes per second, then 1 big box is 0.2 seconds. And divided by 5, you get 0.04 second per small box. So 1, 2, 3, 4, 5 is 1 second. So 1 box is 0.2 second, and 1 small box is 0.2 divided by 5, which is 0.04 seconds. This is important when it comes to finding out whether the QRS is wide or narrow. As I mentioned before, less than 60 is brady and more than 100 is tachy. So we've answered the second question. First, electrical activity present. If the electrical activity is present, what is the ventricular rate? You all know how to calculate the ventricular rate now. Okay. So that's another picture showing the ventricular rate for 300 divided by 4, 75 breaths per minute. And this is what I was telling you about. If the ECG runs at 25 millimeter per second, that's 5 boxes. And 1 large box is 0.2, 1 small box is 0.04 second. Okay. You can use this calculation, or you can use this formula 300 divided by RR if the RR interval is regular. So here the RR interval is regular. So you have 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4. If the RR interval is irregular, then you cannot use this formula. For example, patient has atrial fibrillation where the RR is irregular, where the heart rate can be high, can be normal, can be low. QRS is irregular. If the RR interval is irregular, then this formula does not work. What you have to do is, that there are 5 boxes in 1 second. You have to calculate the number of QRS complexes in one 5 segment duration, or the other way is The rhythm strip is typically 10 seconds long. Rhythm strip is the strip that is taken either separately or it is the last waveform on a 12-lead ECG. So it's typically 10 seconds long. You calculate the number of QRS complexes in the rhythm strip and multiply it by 6, you get the heart rate. If the RR interval is irregular, this is what you would use. Okay. The next one is what is the in this one, there are some examples for the ventricular rate. The first example, I have 1, 2, 3, 4. The first example, the heart rate is 75 or the ventricular rate is 75. In the second example, I have 1, 2, 3, 4, 5, 6, 7. If you add some of it and some of it, let's say it's 8 large boxes between the two R waves. It's about 38 or 40 per minute is the heart rate in the second example. The third example, this is tachycardia. So this is normal heart rate, 75. This is bradycardia because the heart rate is below 60. Here, it has about let's say two big boxes here. So two big boxes, 300 divided by two big boxes is 150. So this is tachycardia. So here it's 75, here it's about 40, here it's about 150. So normal rate, bradycardia, tachycardia. So that's the second question done. Third question, is the QRS regular or irregular? I mentioned already, count the number of boxes between two R waves and look at the subsequent RR interval. So here it's 1, 2, 3, 4, and here it's 1, 2, 3, 4, here it's 1, 2, 3, 4, here it's 1, 2, 3, 4 boxes. Whereas here you have 2.5 boxes, 1 box, and then 3 boxes, 2 boxes, 1 box, 2.5 boxes. So this is clearly irregular. The 5mm squares between the two R waves are clearly irregular on this side, whereas it is regular on this side. That's question number 3. If so that let's move on to question 4. Width of the QRS complex. So I mentioned already that if you have the speed set at 25 millimeter per second, then 5 boxes is 1 second, 1 box is 0.2 second. So within 1 box, there are 5 small squares and each square is 0.04 of a second. So you have to measure or count the number of small squares from the beginning of Q to the end of S. Q to the end of S. So from the beginning of Q here to the end of S is here. So that is the QRS complex. And find out how many small squares the QRS complex is occupying. Usually it is 3 or less small squares or less than 0.12 seconds. It's 3 or less smaller squares. If it is 3 or less smaller squares, all it tells you is the rhythm is originating in the atrium or the upper chamber above the ventricle, or we also call the rhythm is starting from the pacemakers above the ventricle from the atrium or SA node, etc. So if it is less than 3 small squares, it's supraventricular origin, above the ventricular origin of the rhythm. If the QRS complex is more than 3 small squares, then the rhythm is originating below the level of the atria or from the ventricles. Okay, so there is some kind of a block going on if the QRS complex is wide. That's all you need to remember. Less than small squares, it's supraventricular. More than 3 small squares, it's ventricular. So 2 examples here. On the right, I have one small square, 2 max one small square. So that is supraventricular origin of the rhythm. It's a narrow QRS. On the left, I have 1, 2, 3, 4, about 5 small squares. So it is a broad QRS. So it is a ventricular origin QRS. This is supraventricular origin. This is ventricular origin QRS. Okay. Next, is there any atrial activity? So can you see P waves is the question. Can you see P waves? P waves present, absent. That's all. Yes or no question. If there are P waves, then there is definite atrial activity. If there are no P waves, then the patient is not in sinus rhythm. So P wave indicates sinus node activity. Let's put it that way. If there are P waves present, then sinus node is functioning well. If there are no P waves, then the patient is not in sinus rhythm. The common cause is atrial fibrillation, where you don't see P waves. Instead, you only see chaotic contraction, which is basically some irregular baseline before the QRS complex. So that is the common rhythm you see, which is atrial fibrillation. So atrial activity present or absent. Okay, so I have two examples here. On the left, you see the P, you see the QRS, you see the T. On the right, you see some undulation, some disturbance like or some rough electrical activity at the baseline. You do not see clear P waves. So here the P waves are absent. Here the P waves are present. Okay. Final question, is the atrial activity clearly linked to ventricular activity? So if you remember your anatomy, impulse originates in the sinus node, it goes to the AV node, and then from there it goes to the ventricles. So P wave is the wave that comes first because that indicates the atrial electrical activity followed by atrial contraction. Then QRS comes. If every P wave is married, if every QRS, I should say, if every QRS is married to P wave, then the atrial activity is definitely related to ventricular activity. P followed by QRS, P followed by QRS. Definitely atrial activity is related to ventricular activity. If P and QRS are totally separate, so P waves are running separately, QRS is running separately, then there is complete dissociation of complete dissociation of the atria from the ventricle in terms of electrical activity. So we call it AV dissociation. Okay, right. So let's look at some more examples of that as well. So there's one more thing that I should talk about. So there are several intervals. We'll only talk about PR interval here. So normally the PR interval is the interval that starts from the beginning of the P wave and ends at the beginning of the QRS complex. So that's the PR interval. Normally it is smaller than a large square. So normally it is under the large square itself. It does not cross the large square. Remember, the impulse starts from the SA node, reaches the AV node, and the PR interval signifies the time the impulse takes from the SA node to reach the AV node. So if the PR interval is longer, long PR interval, like here P followed by a very long QRS, then it indicates there is some problem in the transmission of the atrial impulse to the ventricle. If the PR interval is really shorter, then the conduction takes very less time to reach the AV node. That means there is some other pathway going on which is conducting the electrical activity really fast. So PR interval normally 0.2 seconds or one large square. If it is beyond that, then there is some problem in conduction, some delay in conduction. It's AV block. Okay. All right. So those are the 6 questions. Let's look at some usual rates. Sinoatrial node, the SA node normally beats at, produces impulses at 60 to 70 beats per minute. AV node is slightly slower, 40 to 50 per minute. And bundle of His is even slower. The Purkinje fiber is even slower, 0 to 40 beats per minute. So SA node is powerful. When it is beating at 60 to 70, AV node and the bundle of His stay quiet. If SA node fails, then AV node takes over and beats at a slower rate. If AV node fails, then bundle of His or Purkinje fibers take over and they beat even at a much slower rate. So on the right side, you have two examples. The top example, you have P, QRS, and T. The rate is about 75. You have P before every QRS. So this is sinoatrial node origin of the impulse. Okay. So here you see P, 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 P. There's a P here as well. So P is running separately. 1, 2, here, P here, which you can't see, it's hidden under the QRS. P, 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 P. So P is separate. So I have 1, 2, 3, 4, 5, 6, 7, 8 P's for 3 QRSs. They are divorced completely. So there is AV dissociation. And if you look at the rate 1, 2, 3, 4, 5, 6, 7, 8, 9 big squares. So 300 divided by 9 is somewhere around 35. So the ventricular impulse or the is coming from the bundle of His or Purkinje system because the rate is about 40, whereas the P waves are running separately. They are not married to each other, so there is complete AV dissociation. So it's important to remember the rate. So when you interpret, use the rate as well to see where the impulse is originating. So I mentioned earlier that a rate above 100 is supraventricular tachycardia, rate above 100 is tachycardia, rate below 60 is bradycardia. So let's look at the tachycardia part. If the rate is above 100, there are only two possibilities. It can be from the atrium or it can be from the ventricle. So from the atrium is called supraventricular. Supra means above. So the impulse is originating above from above the ventricle. So it's called supraventricular tachycardia. If the rate is high and if the impulse is originating in the ventricle, then it's called ventricular tachycardia. So only two important types that you need to remember. In the supraventricular tachycardia, you have what is traditionally called SVT at the bottom. So really fast rate. So a couple of QRS, couple big squares between the R's. So the heart rate is about 150 here. Here, you have what we call atrial fibrillation. I'll talk you through all of these in a minute. So here, what we call atrial fibrillation is there. It's the RRs are irregular. The QRS complexes are irregularly irregular. There is another rhythm called flutter. So you only need to remember 3 rhythms: atrial fibrillation, atrial flutter, and supraventricular tachycardia, SVT. So in flutter, you see sawtooth-like waves, like really sharp waves before QRS complex. And if you count the number of sharp waves before QRS complex, they will be the exact same for each and every QRS. For this one, let's say 1, 2, 3, 1, 2, 3, 1, 2, 3. So T followed by 1, 2, 3. 3 P waves, and these are not called P waves, they are called flutter waves. They are sharp and they are sawtooth like. And if you look at the QRS, they are regular. So atrial flutter has regular QRS with sawtooth flutter waves. Atrial fibrillation has irregular QRS with just undulating baseline called the fibrillation waves. Okay, supraventricular tachycardia, you cannot see P waves and it is significant tachycardia. So the 3 narrow complex tachycardias that you need to be aware of. In the ventricular tachycardias, I mentioned already that the impulse is supraventricular in origin. The QRS complex is going to be narrow. If the impulse is ventricular in origin, the QRS complex is going to be broad. Here, these are QRS complexes, and they are really broad, as you can see. So you can 1, 2, 3, 4, 5, up to 6 small squares. So that's clearly more than 3 small squares. So this is broad complex. Number one, it is tachycardia because there is only one big square between the R and R. So about 300 is the rate. So it is tachycardia. It's broad complex tachycardia. Therefore, it's ventricular in origin, and the complex is all look similar. So it's called monomorphic ventricular tachycardia. It's ventricular tachycardia. Mono means same, one. Morphic means morphology. So all of them have similar morphology. They all look similar. It's tachycardia, it's broad. So it's ventricular tachycardia, which is monomorphic. Here, once again, you see broad QRS complexes. The complexes are broad. It is tachycardia, about 300 or even more than 300 if you look at the 2Rs. But what you do see is the waves have different morphology. This is different from this one. This is different from this one. This is different from this one. So this is called polymorphic ventricular tachycardia. What you also see, this looks like twisting points. So it's also called Torsades de Ponte or polymorphic ventricular tachycardia. It's ventricular tachycardia because it's broad and it's tachycardia, and morphology is several morphology. So it's polymorphic ventricular tachycardia. It's only 2 ventricular tachycardias that you need to remember. 3 atrial rhythms, 2 ventricular rhythms. You remember. There are only 2 conduction blocks you need to remember. One, I already mentioned, if the PR segment is longer than one big square, from P to the beginning of QRS complex, if it is longer than one big square, then there is a delay in conduction from SA node to the AV node. So that is called first degree heart block. The easy one at the bottom is P and QRS are divorced. P is going at a separate rate, QRS is going at a separate rate. And that is third degree heart block. Any block in between, like dropped beats here. So there's a P, there's no QRS. There's a P, there's no QRS. Any block in between is called second degree heart block. I will not go into the details of it. I just want to keep it simple, and I just want to do the basics first. Okay. Right. So the reason why we talk about blocks is in the second and the third degree, you're going to be dealing with bradycardia. So you will see that on the monitor in the ICU. So it's important that you also know about the blocks. So I want to quickly go through the differences between flutter and fibrillation. I mentioned that already. So if you look at your 6 questions, is there any electrical activity? Look at the right side. Yes, there is electrical activity. Number 1. Number 2, what is the ventricular rate? 2 big squares. So ventricular rate is 150 per minute. So if the ventricular rate is above 100, it's a tachycardia. There is electrical activity. It is a tachycardia. Is the QRS regular or irregular? As you can see, the number of big squares between R's are regular, only 2 between all the R's. So it is regular tachycardia. Number 4 is it narrow or broad? Is the QRS narrow or broad? You can see it's only 2 small squares. So it's narrow complex regular tachycardia. So if it is narrow complex, the impulse has to originate from the atria. So this is supraventricular. Atrial tachycardia is, again, supraventricular is impulse originating in the atrium. So it is called supraventricular tachycardia. Here, once again, going through the same, electrical activity is present. The ventricular activity is the ventricular rate is variable. Here there is 1 big square. Here there are 3 big squares. So you cannot use the 300 by RR rule here. You have to count the number of QRS complexes in the rhythm strip. That is for 10 seconds. So let's say this is done for 10 seconds. 3, 6, 9, 12, 14 multiplied by 6 is about 84 is the rate on this side. The next one is the QRS regular or irregular? Clear, this is irregular. So here it's irregular, number 1. The rate is about 84. So it's in the normal range. The QRS is narrow, as you can see, it's occupying only one small square. Do you see any atrial activity here? The answer is no. I do not see any atrial activity. I don't see any P waves. Instead, I only see undulating waves here. So there is electrical activity. It is irregular. The ventricular rate is about 84. The QRS is irregular. It is narrow complex. I do not see atrial activity. If I don't see atrial activity, but if the QRS is narrow, then I can only call it as atrial fibrillation. So atrial fibrillation on the right and the SVT on the left. So this is something that we already talked about on the left. So there is electrical activity. The ventricular rate is about 300. The QRS is regular because between two R waves, there is only one large square. The QRS is quite broad. You can see it's going up to one large square. I can't see any P waves. Here it is tachycardia because the rate is about 300. It is a broad complex tachycardia. If I say it's broad complex tachycardia, the impulse need to originate from somewhere below the AV node. So it is ventricular tachycardia. Like broad complex tachycardia, ventricular tachycardia. Since the morphology is similar, we call it monomorphic ventricular tachycardia. Compared to the one on the right side, there is electrical activity, yes, but you don't decipher any waveforms here. It's chaotic, up, down, it's all over the place. This is ventricular fibrillation. So when the QRS is chaotic, it's ventricular fibrillation. When the baseline, this is QRS, when the baseline is chaotic, when the atrium goes chaotic, it's atrial fibrillation. Okay, one slide on ST segment, I'm nearly done. So I mentioned already ST goes up or down, then it indicates myocardial ischemia. So this is the P wave and this is the QRS complex. The S is here and the T starts here. So this is the baseline where you see the baseline and then the P wave and then the PR segment. Clearly, the ST segment has risen up. It is quite high compared to the baseline. So this is called ST elevation. Here, this is the baseline. You see the S and then the T here. So this is the ST segment that's gone down. So this is ST depression. So on the monitor, if you see the ST above baseline, then there's something wrong, or below baseline, then there's something wrong. You should record an ECG to see if there is any myocardial ischemia or if the patient is suffering from a heart attack. Okay. One slide on valves and leads you need to be aware. So this is just a representation of where you keep your chest leads, V1, V2. So V1 on the right, V4 on the left, fourth intercostal space next to the sternum on each side. V4 is to be fifth intercostal space mid-clavicular line. V3 is between V2 and V4. 5, 6 goes laterally. So V5, 6 represents the lateral wall of the heart. V3, 4 represents the anterior wall or the front wall of the heart. V1, 2 represents the septum, interventricular septum. The lead AVF is on the left leg, and 2 and 3 are linked with the AVF. So 2, 3 and AVF represents the inferior or the bottom wall of the heart. So when you interpret the ECG, when you're thinking of a heart attack, you need to remember the walls and the leads as well. Okay. So that's the end of my talk. I've got some questions. Dr. Nilanjan, can we go through the questions?
Yeah, sure. So thank you, sir. That was such a comprehensive talk on the basics of ECG, and sir has mentioned clearly the algorithm. He has mentioned clearly 6 steps which we need to use for interpreting the ECG.
Okay, so I'll
Sir,
put the
I
question.
think you have to continue. Yeah.
So I think any one of you can answer. So I put the 6 steps on the left so that it will be easier for you to interpret the rhythm.
Yeah. So can anyone please answer? You can
You can put it in the
answer.
chat
You can
box.
put your answer in the chat box, or you can raise your hand. We will unmute you. Anybody? First ECG. Think we can just go through the 6 steps. Somebody has raised his hand. Okay, I'll unmute you.
Go ahead.
Yeah. 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 Please speak. Mr. Pradeep. Pradeep. Pradeep, are you there?
Sir,
Hello.
What is the rhythm?
Mr. Pradeep Gautam, please make your video on.
Mr. Pradeep. No, I think he's not.
Okay.
Shall I talk to them through again,
Miss
sir? So
Sinai
be more better.
CGO, Miss Sinai CGO, please,
Sinai
please
Sijo.
unmute and please.
Unmute yourself. Sinai Sijo. Hello. Okay, if you're unable to speak, then you can put your answer in your chat box.
Yeah, put the answer in the chat box.
Okay, Hemendra Parmar has told irregular rhythm. Okay, let's go through the, perhaps I think we can start systematically. Is there any
Uh,
electrical activity? There is
I'll do that.
electrical activity, right? Yeah, there is electrical activity.
I'll do that, sir.
Okay.
Not a problem. So there is electrical activity here, as you can see clearly, multiple QRS complexes. What is the ventricular or QRS rate? So clearly, you cannot use the RR by 4 formula here, because just a look at it says this is all irregular. Okay, so you have to count. So the bottom one is the rhythm strip. So it's 10 taken for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 10, 12, 14, 17, 22 multiplied by 6. So 10 seconds multiplied by 6 is 1 minute. 22 multiplied by 6 is about 132. So it is 132. Ventricular rate is 132. It is tachycardia. Is the QRS rhythm regular or irregular? We just mentioned it's irregular because between the two QRS, this is the number of big squares is not fixed. Is the width of QRS complex narrow or broad? It is narrow. You can see very clearly. I mean, it's not all that, may not be all that clear for you, but it's only 2 small squares per QRS. So it is narrow complex, irregular tachycardia. So we said if it's narrow complex, it is atrial. And if it's irregular, it's fibrillating. So atrial fibrillation is the diagnosis. Is there atrial activity present? Answer is no. You don't see any P waves. Is the atrial, I mean, if they don't see P waves, then there's no point in answering the 6th question. I'll put the next one. Let's see if you guys answer the next one.
Few people have answered actually. So good.
Okay.
Those who have answered, excellent. Okay, next question. So anybody wants to interpret this? Yeah. Please put your answer in the chat box, or you can raise your hand. We'll unmute you. No one for this?
Anybody?
Again, sir has
Come on,
put
it's
the
very
6 steps.
simple.
Sir has put the 6 steps. Okay. Somebody has said normal sinus rhythm.
Perfect. Very good. So yeah, there is
Good.
electrical activity.
Good.
The ventricular rate is 4. 300 by 4 is 75. QRS rhythm is regular because between two R's, there are only 4 big boxes. Width of QRS really narrow. Atrial activity is present because P wave is present. And for every QRS, there is a P. So it is not tachycardia. It is narrow complex, P present, and P is married to QRS. This is normal sinus rhythm. Very good. Whomever answered, very good.
Yeah, most of them have answered. Good. Okay, next one. Somebody has put SVT, 2, 3. Most of them have put SVT.
Very good. Super. So there is electrical activity. The ventricular rate, 2 boxes between 2 hours. So it's 150. So it is tachycardia for a start. And it is regular because there are only 2 boxes between 2 hours. Width is narrow, so narrow complex. Regular tachycardia is supraventricular tachycardia. It originates from the atrium, so it's supraventricular tachycardia. Atrial activity present, you don't see P waves, and if you don't see P waves, no point in answering the last one. Very good. SVT is the answer. Very easy.
Okay, somebody has answered. Good.
VT, yeah, very good, super.
Most of them.
So there is electrical activity. Yeah, so there is electrical activity clearly. The ventricular rate, I know, which is about 300 by, let's say, 2 boxes, about 150 or more than 150 in this. Regular or irregular is damn regular. You can see it very clearly. It's regular. The width of the QRS complex really broad. So it's taking one full square. So it's broad. You cannot see any P waves, and no point in answering the last one. So it's tachycardia, it's regular tachycardia, it's broad complex tachycardia. There is no atrial activity. So it's ventricular tachycardia because it is all looking the same. This is monomorphic ventricular tachycardia. If you say ventricular tachycardia, that's good enough.
Yeah.
Fifth one. Okay, so we have very good.
Yeah,
Okay,
everybody is answering. Yeah. So I think,
very nice.
sir, everybody has really understood your class. Everybody is answering pretty well. They have been answering the
Or
question.
maybe it's all too simple for them.
Okay.
So there is, you can see some electrical activity, but you cannot answer any of the other 5
Any of the
questions.
questions.
All chaotic. It's chaotic. So it is a ventricular fibrillation. If you see chaotic waves, it's fibrillation. If you see QRS with chaotic wave, it's atrial fibrillation. If you see just chaotic waves, it's ventricular fibrillation. Okay. All right. ST segment. I just want you to say tell us where you see the ST segment elevation in this ECG, which leads, and where you see ST segment depression in this ECG. Or if you can give the answer, that's also good.
Okay.
You can also tell us which heart attack it is. Anybody?
Inferior wall MI is what most of them are saying.
Very nice. So
Good.
2, 3 AVF, you see ST clearly elevated, and correspondingly V1 to I did not go through the reciprocal changes and all. So you also see elevation in V6 as well. So 2, 3 AVF is predominant ST elevation. So this is inferior wall. That's why I put the leads and walls. Next one. Anyone? V12 septum, V34 anterior wall, V5 lateral wall, 2, 3 AVF inferior wall. Where do you see the ST elevation here? Or the answer? Okay, perfect. So Yeah.
Yeah. Somebody, is it just V4 or any other leads? Okay.
You see ST elevation V1, 2. So clearly, this is the baseline. This is the ST. So this is the baseline. This is the ST. Baseline, ST is way above here. So you see it in V1, 2, 3, 4, 5. So all the leads, anterior anteroseptal MI. This is, sorry, anterior wall MI, not anteroseptal. Anterior wall MI. Somebody has answered it correct. Correct. Okay. Move on. That's it.
Yeah.
Nilanjan, thank you.
Yeah. Thank you. Anybody has any other questions regarding interpretation or anything else they want to share or they want to ask something else? I really appreciate that most of them have answered the questions. That's usually in the they don't answer much. So it's really great that they have answered most of the questions and they've
Either the
understood
questions
most
are
of
very
the things.
easy or they are very good.
So I think yeah, it's like they were listened attentively. So probably they would have got that order. They would have got the algorithm. So they must have used it well and answered.
So I mean, even if you
So
find everything, if you just follow the 6 steps religiously, you should be able to decipher most of the rhythms.
okay, I think then we can end the session. Anything else? Any comments? I think everybody has told you thank you and nice session.
Thank you.
Yeah.
Thanks for attending and listening.
Yeah.
Okay.
Okay. Okay. Then thank you, sir. Thank you, Devachandran sir, once again for such a good class for everyone. And I think we'll end the session here. Okay.
Yes, sir. Thank you, sir.
Yeah.
So with your
Thank you.
Thank you.
permission, I'll end the session.
Yeah. Thank you.
Thanks, Dr. Nilanjan. Thanks,
Yeah.
Deepa. Thank you.